And good afternoon, everyone on the call. Sorry for the late start to this webinar. We're trying to sort out a few technical issues. This week, the WHO and Africa CDC declared monkeypox, Mpox, formerly known as monkeypox, a public health emergency of international concern, which has led to countries to increase their public health response in areas of surveillance, lab capacity, risk communication, case detection. And Ghana, as part of the global community, has undertaken the same measures. So it is important that we have undertake this webinar to be able to bring some level of awareness, because we believe that the clinicians are the first step to picking up all monkeypox cases in the country, and early detection of cases what lead to better response. So this webinar is just to sensitize our clinicians on monkeypox. So mainly we'll be looking at areas of Mpox surveillance, looking at how to be able to early detect cases. Then the second one will be on picking mainly sample management, which will look at taking the appropriate sample, how to transport them, and even the various laboratories that the samples will be taken to. Then the last part will be case management, including managing actually suspected Mpox cases and confirmed cases and other IPC-related activities. Then we'll take the question and answer session. So to introduce us to, our objectives of the workshop, why we are here, and the expected outcome, I'll invite Dr. Dennis Lai, Deputy Director Surveillance of the Ghana Health Service, to make that presentation. Thank you. And over, Dr. Lai.
Yeah, thank you very much, Dr. Tab, and good afternoon to colleagues on the call. It's a Sunday afternoon. I see our president is also on the call, Dr. Serbo. Special greetings to you, and thank you for the opportunity. As Dr. Tab indicated, Mpox has suddenly ramped up on us. It's been declared a public health emergency globally, and even though as a country we have not had any cases, and I'm sure Dr. Atta in his presentation will give us some more insight onto what we've been doing as a country as far as Mpox is concerned, we cannot sit back and say that because we don't have any case, we would do nothing. The reality is that once there's heightened surveillance, we are likely to pick more cases. And as a department within the Ghana Health Service, the Disease Surveillance Department is bracing itself together with our colleagues in the lab, the National Public Health Reference Lab and the Noguchi Memorial Institute for Medical Research, for more samples. And one thing I want to say, maybe before we go into the workshop objectives, is that previously we've not thought of monkeypox or Mpox as the case may be. And it's mostly been linked or been classified as chickenpox in most cases. And the reality is that in the last outbreak we recorded in 2022 and 2023, we got quite a number of the cases actually turning out to be chickenpox. And so we know that these things are being reported. And now that we are going to heighten surveillance on Mpox, we are likely to also see similar cases. So I'll just give a brief background before we zoom into the various presentations. Ghana uses what we call the Integrated Disease Surveillance and Response strategy for our disease surveillance. And this is adapted from the World Health Organization. It's actually undergone 3 revisions. So we are currently implementing the 3rd edition, which we worked on in 2020. We've been implementing IDSR in Ghana since 2002, I should say. And in 2020, when we revised it, one of the diseases we added to our priority diseases was Mpox, even though we had not at that time confirmed any case. And it came in really handy when in 2022, we, among many countries, reported Mpox, and we also reported cases in 2023. And as I indicated, heightened surveillance that followed initial reports of cases in other countries is what resulted in us as a country also picking some cases of Mpox. And so surveillance is a very critical tool in this. And whilst we did not see any cases, some countries continue to report cases, and indeed, especially DRC, where there's also evidence of emergent clades, which I'm sure Dr. Comey will talk more about in the natural history and the clinical presentation. But on the 13th of August, 2024, the Africa CDC declared Mpox a public health emergency of continental security. So PHECS. And as we can see, the Director General in the picture on top during the declaration on the 13th. And on the 14th, the WHO also declared Mpox a public health emergency of international concern. And they linked this mostly to the upset of Mpox in DRC and a growing number of countries in the African region. So it's been declared a public health emergency of security concern by the Africa CDC and a public health emergency of international concern by the WHO. Now, when we get such declarations, it not only highlights the public health significance of the disease, but it also calls for more concerted efforts because we need to reduce morbidity and mortality and possibly return to normal levels or normal situation preceding the declaration. And the declaration by Africa CDC and WHO also means that we're going to prioritize Mpox as far as resource mobilization and allocation is concerned. And I'm sure that we all have COVID in mind. We know what went into getting resources and also getting the necessary measures put in place to deal with that pandemic. The declaration also indicates high-level political commitment. Governments all over, once the WHO declares a fake, or in this case, the African Union declaring the first, means that political commitment would automatically set in to address this specific public health emergency, and in this case, Mpox. And so for us in the health sector, what it means for us, especially in Ghana where we haven't reported any case, and I'm sure we all remember the period preceding the recording of COVID in Ghana, the heightened surveillance and all the rumors and the things we had to deal with. And so we need to look at strengthening our surveillance system, promptly investigating all suspected cases and managing them appropriately, and also addressing all the issues that come with such public health diseases. And so community engagements and risk communication ought to be looked at. In addition, particularly for clinicians, and I have to say that we know that there's not only clinicians on this call, even though the focus is primarily clinicians. But for clinicians and also for other health care workers, it is essential that we look at the spectrum of activities that are to be undertaken as far as this is concerned. So from surveillance to case management to outbreak investigations, contact tracing, all the things that need to be done as far as Mpox is concerned. And so this is what drove us as a department within the Ghana Health Service, the Disease Surveillance Department, to collaborate as usual with the Ghana Medical Association to organize this CPD. And our objectives are to review the global, regional, and national situation as far as the Mpox is concerned. We also want to be clear as far as the natural history of the disease is concerned, so that this would inform some of the actions we take. We also want to be mindful of the fact that not all presentations may be Mpox. And so to look at the differential diagnosis and how to appropriately identify those that are likely to be Mpox and investigate them appropriately. But most importantly, case management and infection prevention and control. Given that it's a highly contagious disease, I think that it's of utmost importance that we refresh our minds as far as IPC is concerned. And then we want to look at surveillance in general, the principles underpinning surveillance for Mpox in Ghana, and also look at the issues as far as the appropriate samples to be collected, how they are to be handled, and transported to the designated laboratories for testing. And we also want to understand the current laboratory testing methods available for practice or currently being used in Ghana. So we will have a presentation by the head of the National Public Health and Reference Laboratory on this. And then to sum things all up, we want to be asking ourselves as clinicians what our role is as far as surveillance and also response for Mpox in Ghana is concerned. So at the end of this workshop, we have 3 outcomes we're expecting. We want everybody on the call to be clear on what we mean when we talk about a disease Mpox. We also want some clarity on the principles underpinning surveillance, the appropriate sample collection and transport, the laboratory testing, the management of cases, both suspected and confirmed, and the infection prevention and control methods available for Mpox. And last, but certainly not the least, that we are all clear, especially for the clinicians on the call, on our role as far as Mpox surveillance and response is concerned, but also for all our colleagues, other health care workers, what our roles will be as far as this is concerned. So we're hoping that in the next few hours that we'll be together, we'll be able to achieve these outcomes as far as this webinar is concerned. So thank you very much for your attention, and over to you, Dr. Tawab.
Thank you very much, Dr. Lai, for the presentation and for laying down, the expectations for these few hours that we'll be together. So next on the agenda will be an overview of Mpox surveillance, where we look at the general principles of surveillance. Then we'll zoom in to Mpox itself. We'll look at the case definitions for Mpox. Then we'll end with the role of clinicians in Mpox surveillance. And that presentation will be taken by Dr. Joshua Ta, a public health specialist and the acting national EOC manager. Over to you, Dr. Ta.
Thank you very much, Dr. Tawab. And I think Dr. Lai's presentation sets the tone for what we would want to cover in this presentation. So we would want to quickly look at an overview of Mpox. And Mpox is a zoonosis caused by the Mpox virus. It's an orthopox virus. And infection in humans occur when a human or a person comes into contact with the virus from infected animals or from another infected human being or through contaminated materials. Now, these animals are typically rodents and other non-human primates. And anyhow that we come into contact, either through their bite, a scratch, or with their body fluids, or even eating contaminated meat of those animals, can actually transmit the virus. For human-to-human transmission, we're talking about close contact with the lesions, with body fluids, and it's also been demonstrated that respiratory droplets and, as we mentioned, contaminated materials can also be part of the transmission. Incubation is typically between 6 to 13 days, ranging from anywhere 5 to about 21 days. And this will be covered in much detail, especially for the case management presentation. So Mpox is quite similar to smallpox. And as we know, smallpox is considered eradicated now. And Mpox has been endemic in rainforest areas of West and Central Africa. Over time, it has become the most prevalent orthopox virus disease, especially with the eradication of smallpox, and also by extension, the loss of protection that smallpox vaccination offered at the population level. When you want to go into the virus classes, you can talk about two distinct subtypes. In the past, these were referred to as the West African and the Central African clades. The new nomenclature to refer to them is the clade 1 and the clade 2 subtypes. And they have some influence on the severity of disease, with the clade 1 typically being known to be more related to severe disease. Mpox by itself can resolve, but especially amongst children, pregnant women, and other people who are vulnerable, mortality rates can go as high as about 10%. And as I mentioned, Mpox has been considered endemic within West and Central Africa. Annually, some countries would report cases across these areas, typically Congo and Nigeria and all that. But in the year of 2022, there was a global outbreak of Mpox, with other countries that typically did not report Mpox cases showing large numbers of people affected with death. And in that period, Ghana also recorded some cases of monkeypox. So back in 2022, Mpox was declared public health emergency of international concern. And by the end of April 2023, even though there was no official communication, there was a general decline, and you could consider that we had come out of that fake situation. However, when you look at this trend here, which chart gives a global picture of Mpox trends between 2022 and now, you would see that beyond that surge that was experienced in June 2022 down to the end of 2022 and beyond, now when you consider the current time and when you move towards the end of the chart, you look, there's a bit of a small uptick. And when you go into that uptick, you would see that the majority of those cases are coming from the Africa region. And that is where the focus for the current concern about Mpox is actually coming from. Now, if you enlarge that small portion that I showed previously, then this is the picture that you get. Down to the end of June, you're seeing a large number of confirmed Mpox cases, especially in the Democratic Republic of Congo. And that's really is where the concern is coming from. In the past few weeks, many more countries are confirming Mpox cases in the Africa region. We want to zoom into Ghana, and I think Dr. Lai has already mentioned this, that back in May 2022, we confirmed our first case. Over the period, we had about 128 confirmed cases from 14 regions, with about 4 deaths. Some of the deaths were still of suspected cases, which could not be tested before they passed. For the current year 2024, there are about 81 suspected cases, if you're considering the time up to the end of July, and these have come from 15 regions. When you look at these cases, about 82% have been tested. The results came back as negative. Just a few that recently were submitted that are pending laboratory confirmation. So for the year 2024, as a country, Ghana does not have any confirmed case of Mpox. But as we are showing, it is part of routine surveillance, and we continue to have cases reported from across the country. Now, to situate Mpox in our surveillance system as a country, and as mentioned in the earlier presentation, Ghana practices the integrated disease surveillance and response strategy. And in there, we track 55 priority diseases, events, and conditions. And these diseases are selected based on our epidemiological situation as a country, our public health needs, and the ability of our public health system to respond or contain these diseases. There are 6 major categories, and what is shown here on the slide is epidemic-prone diseases which require immediate reporting. And as you can see there, Mpox is one of those diseases that is considered a priority disease for the country. And so beyond the global concern about Mpox, as a country, we have always had Mpox on the list of our priority diseases. And again, as mentioned, once it's become a public health emergency of international concern, then we also want to step up our efforts as surveillance to be able to quickly detect and to contain if we have these cases here. Now, how do we conduct Mpox surveillance? We are mostly familiar with what is referred to as indicator-based surveillance, where we use standard case definitions to be able to detect and notify suspected cases. For Mpox, we adopt case-based surveillance, where detailed information about each suspected case is collected and followed up. Then we also have what is called the event-based surveillance. And for event-based surveillance, we are paying attention to unstructured information from all sources, community sources. It could be from ourselves as health professionals, observing something unusual in our workplace. It could be information on social media, all these things that could prompt the system to think that there could be this disease being found elsewhere, even if it's not coming through the formal health system as part of the indicator-based surveillance. We also do active surveillance, which is public health officials actively coming around to conduct record review and seek information on cases that may have been picked. And then, of course, passive surveillance, where you sort of wait for someone to say that we have this and bring it to the notice of the system. So all these approaches come together to ensure that our surveillance system is highly sensitive and in a position to detect these suspected cases of monkeypox and other priority diseases if they were to happen in our jurisdiction. For surveillance of monkeypox or Mpox, the 3rd edition IDSR that the first presentation referred to has the surveillance goal. And the idea is to detect and immediately respond to any suspected case of Mpox. It's important to note that this is the surveillance goal. And so once there is that clinical suspicion of monkeypox, we really want to quickly move in and take all the necessary actions. We're not going to wait till laboratory response comes and says this was a suspected case of monkeypox, by which time most of the things that should be put in place may actually be a bit late to do so. So we all want to take note of this surveillance goal. We are looking at being proactive when we even have suspected cases of Mpox. Now, for the indicator-based surveillance, we use a standard case definition. And I think some of us would have seen this case definition either through our participation in some IDSR trainings or in the very recent alerts issued from the Director General to all health staff. And we are looking at a suspected case as any acute illness with fever greater than 38 degrees Celsius, intense headache, lymphadenopathy, back pain, myalgia, and intense asthenia, which is followed 1 to 3 days later by progressively developing rash. That often begins on the face and then spreads elsewhere on the body. And it can affect the soles of the feet and the palms of the hand. So these are the criteria that would make us consider the possibility that the patient in front of us could be a potential case of Mpox. And I think when we go into the differential diagnosis presentation, there will be a bit more detail on these things. For public health purposes, then a probable case is a case that meets this case definition but has not been laboratory confirmed, but we can also demonstrate a link, a epidemiological link to a confirmed or other probable case. So that is the levels of the case definition that we want to be familiar with. For a confirmed case, clearly that is the case with this case definition, suspected case definition, but it's also laboratory confirmed. And we are always aiming to be able to confirm the cases. And as we go on, we'll look at the roles that all of us can play to ensure that we can always end up clearly confirming or clearly showing that our cases are not confirmed cases of Mpox. I'm adding a bit of actions, public health actions, for what we do when a single case of Mpox is suspected or confirmed. And as we see here, the actions take are to report case-based information to the appropriate level. So typically from the health facility to the district and up all the way to the national level. Immediately, we want to take steps to isolate the patient, to ensure that we have airborne infection control as appropriate. And staff attending to the patient should also be using the appropriate PPEs. We'll look a bit more into treatment, and it's typically around supportive care and symptom-specific management. Also, the need to collect and transfer specimen under strict IPC conditions for confirmation testing. There's a need for risk communication, community engagement, contact tracing, and contact management. As we said, it is spread through contact. So right at the point where you suspect a case of Mpox, it is important to identify who has had significant contact with this case. Begin with contact listing and look at how we communicate the risk to especially close family members and friends. There is a need for active surveillance to identify additional cases. Have there been cases that may have come to the facility in the past few weeks that because maybe we were not really thinking about Mpox, we may have misidentified altogether? There will also be the need to identify the WHO as you have a suspected case, thinking about the possibility that this case could become confirmed. Now, what happens when a single case has been confirmed? Now, once that is confirmed, then the infection control measures put in place have to be maintained and even stepped up. We are looking at early detection and care. A lot of these in the 2022-2023 outbreak, a lot of the cases were generally well and were being managed at home. You would need to have support for their management so that you also are able to limit spread of the disease. There is the need to continue with community education and get community to support the measures that need to be put in place in order to control the disease. And then, of course, in the community, there's the need for active case search for additional cases. Monkeypox can be very stigmatizing, and so it is important to have the community on your side so that we can look at all the support community can give in identifying and getting those that have the cases to care. So we would want to round off by talking directly about our roles as clinicians when it comes to Mpox surveillance. And the first we want to talk about is clinical detection and notification. If we are not detecting Mpox, then the whole cascade does not even start. So our ability to identify and diagnose Mpox cases using the standard case definition is key. And we need to know how such cases come to the attention of the health system. Many of us have public health units in our facilities, or we have the district health teams. And so we should be able to know how we link up with them to bring to their notice that we are suspecting a case of Mpox, and then bring them on board to be able to support the activities that should take place. We also have a role to support the public health investigation. As we mentioned, Mpox is handled through case-based reporting. So there is detailed history and clinical details to be reported on each case. This information would come from the clinician. And so there is the need for that support for the public health officers to be able to complete the case-based reporting as part of investigating the suspected case. Then we mentioned testing, laboratory testing. Laboratory testing is done through collection of specimens. So the appropriate specimen has to be collected, and this needs the support of a clinician, whether it's taking blood or taking a piece of the scalp or lesion for laboratory confirmation. Then there are times that there's a need to perform outbreak investigations, either in the cohort that is affected in the community. And based on the scenario or circumstance, the team investigating the outbreak may need the support of a clinician to be able to do that investigation properly and to document whatever findings accurately. Case management, and as mentioned earlier, there will be a whole case presentation on case management. The isolation of suspected cases is important, and the clinician has a key role to play in ensuring that that is done and done properly. As clinicians, we have the responsibility to apply the relevant IPC measures, both to protect ourselves and others. We also have the role to provide supportive care for either suspected or confirmed patients. A few times, diseases are labeled as public health diseases. And I like to say that there is no public health disease. All diseases are public health diseases. And as clinicians, what we work on are public, and everything that we work to diagnose and support patients on is a duty that we have to the patients. You find sometimes people neglecting to support either suspected or confirmed patients of priority diseases, either due to fear, that due to complaints about lack of the necessary equipment and support. There is a need to work together so that all these can be provided, and then we can dispense our duty to provide such supportive care for such patients. Then comes health education. So we need to know at least the basics of Mpox so that we are in a position to provide some health education to the patient and to relatives on the outcomes and the other preventive measures. We know that in our settings, the clinician is considered paramount when it comes to the information that the patient wants to hear and will take note of. So as clinicians, we want to know the very basics about Mpox so that we are in a position to share that information with our patients and our relatives when it comes to especially adopting the preventive measures. So this sums up some of the key roles that as clinicians we can play to support Mpox surveillance to aid the rapid detection and notification of Mpox if it appears in a facility or place of work. So to sum up, we have tried to show that Mpox has been endemic in West and Central Africa for years. However, from 2022, there was a global Mpox outbreak that saw a large number of cases in regions that did not traditionally experience and report Mpox. Beyond that, in 2024, there has been a surge in Mpox cases in countries, DRC and other countries in Africa. And this has led to the declaration of Mpox as a public health event of international emergency of international concern. For us in Ghana, we recorded cases and deaths of Mpox in the 2022-2023 outbreak. But for this year, 2024, we have not had any confirmed cases, even though routine surveillance has had about 81 suspected cases reported and tested. And so for this reason, there is a need for us as clinicians to have heightened awareness, to detect, to promptly notify, and to support the investigation of all suspected cases of Mpox. Thank you for your attention, and we'll be here for questions.
Okay, thank you very much, Dr. Atta, for the presentation. For taking us through the whole surveillance structure, Mpox surveillance, how to be able to identify suspected cases of Mpox, and our roles as clinicians when we suspect an Mpox case or there's a confirmed Mpox case. So now we've learned how to identify various Mpox cases using the case definitions. After we've picked up suspected cases, it's important that we pick the appropriate samples. So we would invite Dr. Gifty Boateng, the head of the Public Health, National Public Health Laboratories Department, to give us a presentation on the appropriate on sample management in general. So Dr. Gifty Boateng, over.
Thank you, Dr. Tawab. May I share my screen? Hello and good afternoon to everyone. I hope my screen can be seen.
Dr. Gifty, we can see your screen. I think you can continue.
Thank you very much. So just as Dr. Tawab said, this afternoon my job here is very simple, to talk about sample management of monkeypox. So at the end of this session, we want to be able to collect samples with appropriate IPC. We also want to be able to describe and demonstrate sample collection and how to transport it to the lab, and then to properly implement decontamination and then waste management at the end of the collection. So to introduce us to the session, for we, the lab, any result we give out is as good as the quality of samples that we get and the time that we receive it in the lab. But this is the point where sometimes we don't take it seriously, and therefore we give you results, and then the clinician says that I am supposed to, with all the clinical signs I'm seeing, I'm supposed to get this result, but then it's not turning out like that. Or you send it to one lab, it gives you one result, to another lab, it gives you another result. The reason is very simple. It is based on the quality of sample and when we receive these samples. And therefore, it is the laboratory's responsibility to make sure that we provide you with the what to collect, the when to collect, and then the how to collect these samples. In Ghana, our disease control officers support us with our disease surveillance systems in terms of lab and sample collection. But then it is the role of the laboratorian to see to it that these things are done well. And so we are supposed to help you. This is monkeypox. So what are you supposed to collect? When are you supposed to collect the monkeypox samples, and the how? It is also our responsibility to make sure that we give you the appropriate containers and supplies to use if we are not the ones collecting them, and then how to label it. And then when you receive it, how to make sure that we assess these samples and make sure that we are working on the right patients or client samples. So we want to talk about the collection. But for us to be able to do a very good sample collection for Mpox, we need the right sample. And here, when we say the right sample, it means the right type for the purpose, the time of collection, and then to make sure that whoever is collecting these samples have been trained. So the right collector is important. We need to follow SOPs, and we also need to make sure that our request forms, and here our case-based forms, are completely filled. This is where sometimes we also fall short when we receive samples. You realize that the case-based forms are not completely filled. We would request that these things are completely filled for us. And also for as one of the key principles for a good sample collection, to make sure that we don't contaminate the sample. We finish and then we are safe, our clients are safe, and the environment is also safe. And also to make sure that we store it properly using the right equipment. So all these are key principles that will help us with our sample collection for Mpox. So what or who should be tested? We, as Dr. Arthur has already introduced us, we have to use our case definition. So any patient who meets the case definition specified by Dr. Arthur, so a suspected case or a probable case is the one that we are talking about. Then the samples that we want is lesions and crusts. And normally we want it during the rash stage, because this is the period that we are going to use PCR. So this is the time that we get a lot of the load for us to do the testing. And we'll be doing contact tracing. And sometimes when we go out for contact tracing, if people are in the incubation period, we do not recommend that we take samples. And then also when we are at the recovery stage, we would collect serum, because at that period, it is just the IgM that we are going to look at. And then that will not be used for our diagnosis. So to continue with our specimen collection, these are the things that we need. We need to get the proper PPEs to wear. So our N95, our gloves, our gowns, our goggles, or face shield, all these are PPEs that are recommended for sample collection. For labeling, we need these things to be with us. Our case-based forms. And then we need a sterile synthetic tip swabs. We prefer a polyester or nylon, dacron, or dry swab, and we don't want preservatives. So we do not want the wooden swabs with cotton tips. These affect our PCR testing. The recommended test for our sample collection is by PCR, and these swabs affect our testing. So you need a sharp, because after that you need to put your shaft inside. We also need autoclave bags, sanitizers, transport medium, and for serum, if you are collecting serum, you need the tourniquet, the syringe, and needle, and EDTA for that purpose. What are the recommended types of specimen that we want our clinicians to pick for us? We want the swabs of lesions, the surfaces, or the exudates. Crust, that is the most suitable one that we want. Oral swab, but we'll talk a little bit about that, or whole blood. The preferred one is the crust or the swabs of the lesions. But we'll talk about why, if we are not getting any of these things, then we can come to the oral swab or the whole blood. After collection, you label with the name or ID, age, sex, date of specimen collection, and then the type. The type, please, is important for us so that we know which type we are dealing with. We want that to be on the specimen collection too. So how do we do this? We wear the appropriate PPE as I listed above. Then you collect 2 swabs from each of 2 lesions from preferably different locations on the body. So you identify any 2 you collect, and then you put in the same tube for us. We want, preferably, if you have different appearances, that will be good for us. You use a sterile dry synthetic swab, as I have described earlier on, and it is not necessary to clean the lesion with ethanol or any other disinfectant before swabbing. It is not necessary to do that. Still, how do you collect it? You swab the lesion vigorously to ensure that adequate viral DNA is collected. And how would you know that there's adequate viral DNA? You observe the swab. If you look at the picture I have on the screen, you see that as he's collecting, you see that the swab is white, it is changing in color. Generally, you have to do this with a firm, so you need to go for a swab stick that have a firm shaft. This would help you to do the vigorous swabbing. If you have a very weak one or a very thin one, applying that firm pressure would not be feasible and it would affect your sample collection. Unroofing or aspirating the lesions is not necessary or recommended at this moment. All that we need is that use a firm shaft with a nylon or dichrome tape, and then you firmly swab the lesions about 2 different times with 2 different appearances for us. If in case you are swabbing and then there's a rupture, we would ask that you collect these lesions, also the fluid that is coming out into the collection tube. And so as you swab, you do that back and forth 2 or 3 times. You turn the swab to another side, you do the same thing, and then you collect this and put in a specimen collection container for us. So 2 lesions, as I've said, is what we want. We prefer that you do not miss the different types of samples I've talked about. If you are collecting crust, put only crust in the same container and don't miss them. Don't miss them. If it is swab, it's only swab in the same container. If it is crust in the same container. You can put in both dry swabs or VTM and send it to the lab. And if you have enough resources, we will prefer that at least you can do this into 2 separate tubes and you can pick all of them. If you have crust, you pick. If you have fluid, and then you have 2 separate tubes and then you send to the lab for us. So the crust, how do we collect that? We use a forceps or any other blunt tip, sterile instrument to remove a piece or pieces of that, and then you put in a container for us, in a dry container for us. And then you cover with plaster in case you take the crust and then you have any blood coming out, you clean and then you cover with plaster. As I said, we can also take oral swab, but this is not the best because data on it for monkeypox, it is not well known. And therefore, if you are finding it difficult to collect any of these things I've talked about, then you can go for oral swabs. But when you bring it to the lab and we give you a negative report, it does not mean that it is negative. So we need to interpret these negative results with caution. That is, if you brought only oral swabs to us. For blood samples, we all know how to do that, but we need 3 to 4 mils of the whole blood in a tube, and then you can bring this one to the lab. As I said earlier on, this is not the best sample that we need because for blood samples, viremia occurs. It's difficult to use this for PCR because we don't have enough of the viremia in there. So we'd prefer the crust. But then if you are unable to take any of the above, then we can still go ahead with the blood samples. At least if you want to see that the person is recovering and you want to take samples for blood, we recommend that. And if we really want to use it for diagnosis, it means we will need a paired serum, but we don't recommend this, as we know that when you have the rashes, that can be sent to the lab for us. As I said earlier on, our testing method is PCR. Our testing method is PCR. So in summary, what am I talking about for sample collection? We are saying that for each patient who meets our case definition, we fill a case-based form, we label our specimen with the date, the type of sample is important to us, and then the age and sex. We do hand hygiene, and then we collect appropriate swab from the specimens that I've described, either the lesions, the exudates, the crust, and then blood, that is if the person is recovering. We package it using the trip packaging, which I'm going to talk about briefly, and then we doff off, and then we do hand hygiene. When we collect our samples, we need to label them. I think I've talked a bit about that with the full name, or if you are using any ID, but we have to make sure that whatever name we put on our samples matches with our case-based form. There are times that we receive samples and then there are different names on the case-based form or even the IDs, and then we have to reject. We are asking that when we take samples, before we send them, we cross-match to make sure that whatever IDs are on our case-based form matches with our samples. This is because if we have any of these samples being rejected, it will delay our reporting results times. It also would have to be doing rate testing. It will decrease our customer satisfaction. That is, you have to go back to the patient because the lab has rejected the sample, and this sometimes is not good for our clients. For here, it will increase also cost, because then you are going to do another sample transportation. If you are coming from maybe the north, we see that it will not help us. And sometimes if we do not reject and we go ahead, it may even lead to death, because then you are going to give a wrong diagnosis to the wrong patient. Now that you have collected the sample, how do you package and transport it to the lab? If you are close to the lab that will be doing the testing, we would recommend that immediately you send it to the lab for testing. And here, which labs am I talking about? The National Public Health and Reference Lab. If you are in Noguchi Memorial, if you are in the northern part, then that is cases here. These are the 3 labs that we were testing for monkeypox. But if you cannot do that immediately and send a sample to the lab, within 1 hour, we ask that you refrigerate at 2 to 8 for us. If you are going to store beyond that, within 7 days, then -20, or if you have -70, which I doubt any of our health facilities, if you are not a public health lab, would have. So these are the recommendations that we want you to keep the samples before you ship. But because we need prompt response, we recommend that as you pick these samples, you send to the lab immediately or within some few hours. We do not recommend the repeat freeze and thaw. So if you know that you are bringing it in the next few days, don't keep it in the -20 or -70, and then when you are bringing it becomes freeze and thaw. When you do that, it affects the quality of specimen and then therefore the results that we get for you. Now that you know the temperature at which you should store the samples, when you are transporting, we recommend that you do triple packaging. And for here, when we say triple packaging, you are using 3 containers to package the sample and send them to us. Your first container, which we normally call the primary container, is either your VTM container or where you have your swabs or your crust. That is your primary container. To prevent breakages, you wrap it in an absorbent sheet for us. And then you put in a secondary container, another container that is be able to screw cap. This is where normally we do not do. We only will pick the samples and put them straight on ice in an external container or the tertiary box, and then we send. Sometimes as we move along the road, it shakes and it gets to the lab. It's either spilled or if the container is a glass, it gets broken. So recommend that we always would use the secondary container, as you can see on my screen. And what you should take note of, as I always say, is that the correct handling and storage of these samples would help us to give you the right diagnosis. So now that you have your sample, your trip packaging, for the documentation and how to keep the case-based form, it is very important that we prevent our case-based form from being contaminated. What sometimes we forget is that when these things get to the lab, we move these case-based forms from lab to disease surveillance and other areas. And sometimes it gets to the lab and it's already contaminated. But these forms will end up on the decks of another officer who doesn't know where it has been. So when you are transporting, we recommend that you put it in a Ziploc bag. And then to prevent, sometimes we use courier services. So to prevent them from seeing what is on the form, you put it between the secondary container and the tertiary container. But this is the case that we normally would not use a secondary container, so it becomes difficult. and therefore it gets to the lab, it's either soaked, it is wet, and sometimes we also give it to the courier service, and then they can read whatever it is there. This is not good for us. For biosafety and biosecurity purposes, we need to prevent some of these things. And we have to make sure that when we pick the samples, we enter the data in SORMAS, because that is where we would put your results. For prompt response, you have to make sure that the sample is entered into SORMAS before you bring, so that just after testing, the lab will go there and make sure that your results are also entered. Then you transport this according to our national guidelines. That is, if you have you are bringing it yourself, that driver has to be trained. If you are using a courier service, they need to be trained also to know what to do and how to transport it to us. And therefore, we transport at a temperature of 2 to 8 degrees. 2 to 8 degrees. Now you have collected it, you have stored it, you have transported it to us. Any waste that comes out of the processes, we would recommend that you decontaminate, and then before it leaves the lab, there should be decontamination, either by autoclaving or you are doing a chemical disinfection, and then the final disinfection is for us to incinerate. That is outside wherever you took the samples from. We are concluding, so therefore, what are the key points? We are saying that sample collection and time between collection for processing is of quality to the lab, because that would help us to give you a quality and reliable results. We also recommend that you rapidly send your samples to the lab and make sure that the carrier and the laboratory can have contact. We need to know when you are coming so that we can also prepare for you. If you are bringing it to these labs, for most of the labs that we are doing this PCR, normally if it is not outbreak seasons, weekends we are not working, so you need to have a communication with us if you know you are bringing it beyond these hours that we work, so that there will be somebody there to receive, and then the sample will also be in good condition. We also have to make sure that we check the carrier to ensure that there is no issue with shipments. We need to consider the types and the number of samples required for proper labeling. And if samples cannot be transported immediately, I have said that we need to store it. If you know you are moving it in the next hours, -2 to 4 is fine. If you know beyond that you can't bring it within those hours, then it means you have to store it at -20. When you are ready, you bring it to us. But we prefer an immediate transport because you need a rapid response to whatever is happening in your district or your facility. It is also your responsibility to make sure that any waste that we generate, we keep it safe before it leaves whichever facility you collected the sample. And in any case, if you are in doubt, our lab people are there for you to seek guidance on what to do. And then we also have to make sure that we record the steps and keep the laboratory informed. To also help to check what we have gone through today, for us to know the proper sample collection kits, we need these items, our PPEs, which includes our gloves, our face shield, and then we need our autoclave bags, our sanitizers. These are things that we need to assemble when we are going to collect our samples. And then what are the collection methods? These are the procedures that we need to go. We fill our forms, we label them, we perform hand hygiene, we take our samples, we package it well, and then we ship with our triple packaging. And then make sure that we are transporting it at a temperature between 2 to 8 degrees. I want to thank all of you for your attention this afternoon. Thank you very much.
Thank you very much, Dr. Gift-Boateng, for the wonderful presentation. Please, now we have some clarity on the type of sample to take depending on the phase of the incubation period. So we'll take our last presentation from Dr. Joseph Olivakomi, who will take us through case management, how to be able to clinically identify Mpox cases, the differential diagnosis, the various IPC measures that we'll put in place when we have a suspected or a confirmed case. So Dr. Joseph Olivakomi, Director, GIDC, over to you. Thank you.
Takome is muted.
Hello, please, can you hear me?
Yes, Dr. Olivakomi, now we can hear you.
Okay, thank you. Good afternoon. Thank you very much, Tawab. Thank you, Dennis, and thank you, Dr. Arthur and Gifty. At least you've made my work quite easy. So we'll go ahead and look at the clinical presentation of Mpox. I must say that traditionally, Mpox usually presents as a systemic illness with these symptoms, and I'm sure apart from the characteristic rash, when you hear fever, chills, myalgia, definitely you're all thinking about a viral illness. But the good thing about Mpox is that it comes with a characteristic rash. However, during the last 2022-23 multi-country outbreak, we have had some patients presenting with genital, anal, and oral lesions without the systemic illness. So remember I said that traditionally, Mpox will present as a systemic illness. But currently, there's reported cases of people with genital, anal, and oral lesions without the traditional systemic illness. So let's keep that at the back of our minds. The clinical progression of Mpox usually goes through the incubation period, the febrile stage, then we have the rash stage, and then the recovery period. We were told earlier on that the incubation period on the average is between 5 to 13 days, but could last as long as 5 to 21 days. That's the incubation period. During which period the person is exposed, but the person has no symptoms. The febrile stage, also known as the prodrome stage, before the rash occurs, may last close to about 4 days maximum. And during this period, that's when you have the fever, lymphadenopathy, which you will find out later is very characteristic of Mpox as compared to the other differentials. The patient may have this headache, chills, sore throat, malaise, asthenia. If you all remember the case definition that was presented, then usually about few days after the development of the febrile period, the characteristic rash will develop. And as we go on, we'll talk about the rash of monkeypox. This may last up till the period when the scabs will fall off. And then we have days to weeks when we have the recovery phase. During the recovery phase, there are no symptoms. So we'll go ahead and look at the clinical presentation. Remember that we had earlier spoken about the fever, the headache, the myalgia, the fatigue. I'd also mentioned earlier that they tend to have a lymphadenopathy, which we all see that it's a key differentiating feature of Mpox from smallpox, for which they are very closely related. And like Dr. Tata earlier on said, smallpox, as we all know, has been eradicated. We spoke about the febrile period, the prodrome, and this usually we said may last close to about 5 days. Apart from the swollen lymph nodes, the fatigue, there may be some respiratory symptoms we spoke about earlier on. And there's a period where the virus is present within the blood. So if you are taking a sample around this time, we may have the viruses found within the blood. There may be some small lesions in the mouth, as I mentioned earlier on. And note that all the patients may not present with the febrile prodrome. or symptoms before the rash. Like I told you earlier on, during the current outbreak, some people have presented with the rash without the prodrome phase. After or within 3 days after the fever, this patient will develop the almighty monkeypox, Mpox rash. Usually it begins on the face, goes to the extremities, including the palms and the soles. The key thing here that these lesions are deep-seated. Initially, they are painful. As we will get to know as they progress, they become crust and they fall off. And the crusts are usually pruritic. How many lesions do you tend to see in a person? It varies. There are some people with very few lesions, just about 10 lesions, and some people may have 100 to 200 lesions covering them. So these are the key things we want to know about the rash in monkeypox. We say that it begins on the face and the extremities. They are deep-seated, initially painful, but they become crust and become itchy as we progress. The number of lesions may vary from small amounts to thousands. And the key thing about the monkeypox, remember we have said that there's a characteristic rash and they may have lymph nodes. Characteristic rash, lymph nodes. The rash in monkeypox, if you all remember chickenpox, we are told that the rashes may present at, or the lesions may present at different forms. So there may be scabs, there may be pustules, there may be vesicles. However, for monkeypox, it looks as if they progress sequentially. So at all stages. So you have initially may start as macules. The macules may last close to about 2 days and progress to papules. Papules may last close to about 2 days and also progress to vesicles. From the vesicular stage, these will then progress to pseudopustules. Remember that for other vesicular lesions, you may have pustules, and this may contain pus. However, for pseudopustules, we say that these are they are filled with debris instead of pus, and usually they become umbilicated with time, and later they become scabs. So we start with macules that may last for close to 2 days, progress to papules, lasting for another 2 days, go on to become vesicles, and may last for another 2 days. The pseudopustules may last close to about 5 to 7 days. Thereafter, they form scabs or become crust, and then they will fall out. Remember, I said the pseudopustules do not contain pus, but then they contain debris, and then they are usually umbilicated. And I'm sure some of us remember when we hear about umbilicated lesions, some of us are thinking molluscum contagiosum. So it's one of the differentials that we will think about. So this is just to show that for the monkeypox or Mpox rash, it goes through the various stages at once. So if it's vesicles, you have vesicles at any particular point in time. If it's the pseudopustules, there are also pseudopustules at the same time. Unlike varicella infection, when you could have different forms at different times. So remember we said that from the pustules or the pseudopustules become scabs, and that may last close to about 3 weeks before they disappear. The clinical presentation, or where do we normally find these lesions? So this has been, we know monkeypox as a traditional illness has been happening from time immemorial in the West African and the Central African region. Most of the time, we see that 95% of the time, lesions are found on the face. The eye may be involved, so the cornea and conjunctiva about 95% of the time. Oral mucous membrane just about 70% of the time. Look at genitalia. 95% of the time, you find lesions in the groin and the anogenital region. The palms and soles of the feet about 75% of the time. One key thing about the rash or the monkeypox rash is that it's centrifugal, meaning that it doesn't go towards the trunk, but then away from the trunk. So you have your face, you have the limbs, upper limbs and the lower limbs, the extremities, as compared to a differential like chickenpox, which we say is centripetal, so that comes closer towards the trunk rather than away from the trunk. So in other presentations in other countries and recent outbreaks, people have included other things like proctitis. So the patient may present with severe anal pain. Others have presented with ulcerative pharyngitis or tonsillitis. There have been some ocular manifestations, conjunctivitis, blepharitis, or some periocular cellulitis. So yes, these patients may present first at the eye clinic instead of presenting maybe at the general OPD. And yes, there have been some neurologic manifestations where people presented just with encephalitis, and then we also found that they had the characteristic rash. These are some pictures of the Mpox rash. So we can see the first one where we have the person's lips or the face. You can see the amplification in the lesions around the mouth, around the nose. You can also see the one with the finger, and then the typical one around the wrist, and then the palms. So these are typical lesions that we may find for Mpox. The next slides are pictures we managed. So these are patients we managed in Ghana with Mpox. So it's not as if we took them as an atlas, but these are pictures of cases that we have seen and managed in some of our facilities that we use for training now. Are there some danger signs in Mpox? Definitely, and we all say that Mpox is a self-limiting disease. Usually within about 4 weeks, you should be fine. The rash should have healed, the scabs falling off, new skin forming. But however, there are some people who may have some problems or complications of Mpox. And this is when we think that the person with ocular manifestations starts complaining of loss of vision. That could be a trigger for you to know that this is severe monkeypox. Or when your patient presents with delirium, loss of consciousness, or convulsions, also think about the fact that this patient may be suffering from a severe form of Mpox. If your patient should present with respiratory distress, or maybe the patient, yes, had Mpox all right, but has superimposed bacterial infection of the lesions, so then it presents with sepsis. When your patient starts presenting with hematuria or inability to produce urine, maybe the kidneys have become involved, and these are danger signs for us to think about severe Mpox disease. What are some of the factors that will influence the cause of monkeypox? Remember, we said that Mpox is a self-limiting disease. However, it's been documented that there are cases of asymptomatic infection. They are few, but that has been documented, so we need to know about it. There are some things that may protect you from severe monkeypox, and one of the key things is perhaps smallpox vaccination. And we know that we stopped smallpox vaccination for some time now. So most of us born after the 79s, I'm sure, are not protected against Mpox, severe Mpox. Post-exposure prophylaxis with smallpox vaccine is also a protective factor. There are some risk factors for severe illness. It's been said, or it's been seen in the literature that children tend to have more severe Mpox, especially with clade 1. People with immunodeficiency or immunocompromised states also tend to have worse prognosis with Mpox. And the invasive route of the infection. So it's said that there are times when you can just by contact, or maybe you have a bite or a scratch from an animal. The invasive route, that tends to have a shorter incubation period, and most of the time tend to be more severe as compared to just the contact, tactile route. And also the clade type. We've learned over time that clade 1 has poor prognosis as compared to clade 2. So Mpox recovery. Once all the scabs have fallen off and a fresh layer of skin has formed, the person is no longer contagious. At that time, there are specific antibodies in the blood, but the scars may remain. Yes, we spoke about some complications of Mpox. It could be corneal infection because the cornea is also involved and may lead to scarring, so may lead to loss of vision. Secondary bacterial infection leading to severe sepsis, multi-organ failure, and may end up with death. Remember, we also asked about difficulty in breathing, so we have abscess formation from the pharyngitis, the peritonsillar abscesses, and may also lead to airway obstruction. We spoke about inflammation of the brain, encephalitis, and in pregnant women may lead to some miscarriages. Eventually, some people will die from Mpox. So how do you manage patients with Mpox? All the patients we have seen so far in Ghana, how have we managed them? There's in-hospital care, and there's also home or out-of-hospital care. Remember, we said that Mpox is a disease transmitted by contact, either direct contact or indirect contact through fomites. So isolation of cases is essential in the management and the prevention of further transmission. Considerations for in-hospital care. So WHO recommends that patients at high risk of complications or those with severe complicated Mpox should be admitted to hospital for monitoring and clinical evaluation. So which are these people? Special populations, young children, people who are pregnant, and those who are immunosuppressed. So what do we do for such people? So we're looking first at people living with HIV. The key thing is that it's unknown whether HIV alters the person's risk for acquiring monkeypox. All we know that the signs and symptoms of monkeypox infection is similar in somebody who has HIV or somebody who is HIV negative. However, for people with advanced HIV, for people whose CD4 counts are less than 200, and for those who are not biologically suppressed while on heart, they have an increased risk of severe disease. And sometimes they may present with atypical manifestations. So yes, they may present with the anogenital lesions or the genital lesions without the prodrome period, or then they tend to have sometimes a prolonged illness. So instead of recovery within 4 weeks, they may end up recovering maybe after 6 weeks. So what do we do for such people? If we think you are not on antiretrovirals, we will start antiretrovirals immediately. The decision as to where to manage somebody, whether it's at home or in a health facility, is based on the degree of immunosuppression. Because if the person is well controlled on antiretrovirals, it's stable and has monkeypox, even though the recommendation from WHO is that such people should be managed in hospital, you and I know our difficulties with isolation places. So usually we may manage such well HIV infected patients on home basis, but then if the person is severely immunosuppressed, has AIDS, or has unsuppressed viral load, we may manage that person in hospital. What about for pregnant women? Well, it's unknown whether the pregnant people are more susceptible to Mpox or not. But one thing we know is that in pregnancy, there may be some fever. So a pregnant woman with fever and a rash doesn't mean that it's Mpox. Remember that there are some dermatosis of pregnancy. So we need to keep these things also at the back of our minds. But what do we do for why are we interested in the pregnant woman? It may Mpox will be transmitted to the fetus during pregnancy or to the newborn by close contact during birth or after birth. It may result in pregnancy loss, some stillbirth, preterm delivery, and neonatal Mpox infections have also been reported. The frequency and risk factors for illness and severity in adverse pregnancy outcomes are at the moment unknown, still being studied. So close monitoring for severe disease and pregnancy complications is very important. Remember that we said earlier on that pregnant women are part of the group who want to manage in hospital. But if they are stable, very few lesions, you can as well manage them on an out of hospital basis. What about considerations for the newborn? Remember we said that Mpox is a disease of contact. Okay, so during the isolation of the infectious period of the mother, direct contact with a newborn is not advised. Separate rooms, best way to prevent transmission from the mother to the newborn. Full-time rooming is not recommended in this case. If the patient chooses to have contact, strict precautions must be taken. No direct skin-to-skin contact, and the newborn should be fully clothed or swaddled. Well, there are times when people still want to hold their babies. So remember that during that period, the patient, not the newborn, the patient should be wearing a well-fitting medical mask. Remember we said that one of the modes also of transmission is by droplet infection. So must be wearing a well-fitted mask. And then the clothes that were used to wrap the baby, as soon as the mother hands over the baby, those clothes are removed. I mean, the linen, not the baby's clothes, the linen removed and also really disinfected. Newborns born to people with Mpox should be placed in isolation. They shouldn't be put in the same nursery as other newborns. Once we are doing things about separating the mother from the child, let's remember to provide resources for coping with stress from separation for these people. What about breastfeeding? We are all aware that breast milk is the best source of nutrition for a baby or for an infant. It is unknown if monkeypox is present in breast milk. It is unknown. So breastfeeding should be delayed until all lesions or the scabs have fallen off and a fresh layer of intact skin is formed. That is when we see that the person is no longer contagious. Provide support to maintain milk production and avoid infection. And breast milk expressed from the patient who is symptomatic or is in isolation should be discarded. And a caregiver can feed with alternative feeds for this infant. What about considerations for children and adolescents? Historically, we said the monkeypox has been documented in children, and for clade 1, tend to give more severe infections in children. The signs and symptoms of the rash is just as similar to what we see in adults. Like I said earlier, on clade 1, for children less than 8 years, tend to present as a more severe disease. So with children, we also need to advise them not to even break the lesions or the vesicles that they see. Very, very important. And make sure that the children are adequately hydrated. There's good fluid intake. What's the prognosis for monkeypox? Self-limiting, like I said earlier on, may resolve within 3 to 4 weeks after symptoms in most cases. Patients, we say, are no longer considered infectious after all the crust are falling off. Clade 2 has a more favorable prognosis with a case fatality of about 3.6%, and clade 1 is more lethal with case fatality of up to about 10.6% in unvaccinated children. So the key question is, we've been seeing vesicular rash, we've been seeing rash-like illness. We have never thought about monkeypox here in Ghana. Now monkeypox is it's a disease of public health importance or concern. And we're also saying that it can be confused with other rash-like illnesses. Commonest amongst them is varicella or chickenpox, smallpox, measles, Tanapox, which is also another African orthopox virus, scabies, molluscum contagiosum, hand, foot, and mouth disease in children, herpes infections, even secondary syphilis, allergic skin rash, drug eruptions. All these things can be confused with monkeypox. What we're saying is that these things are the ones we know already. Now we are learning about monkeypox. It shouldn't be that now every vesicular rash or any rash is now monkeypox, and now you are ruling out other things. You make your diagnosis and let's rule out monkeypox. Remember also that we could have co-infections with monkeypox. So you could have somebody with secondary syphilis and also have monkeypox at the same time. So let's keep that at the back of our minds. Okay. We shall look at how to differentiate monkeypox from the common confusing like rash. I'm not going to try to be the dermatologist here. I'm sure we have some dermatologists on the call, and so during the Q&A, I'm sure we can fall on them to clarify some of these things. But for Mpox, chickenpox, and measles, these are the commonest. They resemble each other. So the first picture is a picture of a young child with Mpox. Remember, we said that earlier, I said that Mpox goes towards the face and towards the limbs, away from the trunk, as compared to chickenpox, which is more towards the trunk. I must say that in my practice, I haven't seen a case of measles yet, but then that's a picture of measles that we can all see. Let's look at these things. So in trying to distinguish them, we've looked at whether there's a fever. For monkeypox, we are looking at the about 3-day fever before the rash. Chickenpox, usually the rash appears quicker. So let's say monkeypox day 3, chickenpox day 2, measles will take about a day 5 rash. The rash appearance in monkeypox, we say, takes time to develop. And lesions are usually in one stage of development. So if it's crust, it's all crust. If it's vesicles, it's all vesicles. If it's pseudopustules, it's all pseudopustules. As compared to chickenpox, which may have lesions often in multiple stages of development. And then for the rash in monkeypox, I said was slow and is rapid for both chickenpox and measles. The rash distribution in monkeypox, we said, is more dense on the face, present on the palms and also the soles. For chickenpox, it's more dense on the trunk, maybe absent on the palms and then the soles. Lymphadenopathy, present in monkeypox, absent in chickenpox, and occasionally measles may be present. If you look at the mortality, for monkeypox may be up to about 10% for clade 1. For chickenpox, hardly do people die from chickenpox. And for measles, we say may vary. So what we really try to look at is the difference between monkeypox, chickenpox, and measles. They are the closest. Smallpox, we say, has been eradicated. Okay. These are other rash-like illnesses. So the first one is varicella, and then we have molluscum contagiosum here, and then disseminated cryptococcal infection. This usually may be seen in people who are immunosuppressed, on people on transplant therapy, immunosuppressive therapy. So, as a clinician, what are the key things we need to remember? One, in taking our histories, history of travel, history of contact, very, very important. So recent travel to endemic areas, interaction with wild animals, if the person is a hunter or the person prepares bushmeat, these are things we need to think about. If you have provided care to somebody, maybe with the monkeypox or chickenpox, we need to find out whether this is also part of it. Be vigilant to the possibility of the characteristic rash and Mpox, but also remember that they may be atypical presentations, okay? Clinicians working in the outpatient clinics or the dermatology clinics may be the first to suspect Mpox. Many patients usually tend to have mild symptoms. It's also said that it's easy to confuse Mpox with some sexually transmitted infections of the herpes type. So always try and obtain also a sexual and travel history and determine if any contacts may also have similar lesions. With respect to physical examination, always remember to perform a thorough skin and mucosal exam for the rash. So anal, vaginal, oral exam for rash. Note also the distribution. If you find the rash, note the distribution of the rash and also the stages of appearance of this rash. This slide has been shared earlier on about what sample to take and when to take them. So treatment. Monkeypox currently, treatment is supportive care. Supportive care. So rehydrate the patient. If the patient has a fever, antipyretics, adequate fluid and electrolyte balance for those with severe monkeypox and sometimes superimposed bacterial infection of the skin. If the person has respiratory problems and needs oxygenation, let's provide appropriate oxygen therapy for this patient. Empirical antibiotic therapy if we suspect secondary bacterial infection. And if we think that it is not monkeypox and it could be varicella, then we can bring in our acyclovir. And I must say that currently, as a country, no vaccine available, and we are not using any approved antiviral yet. How do we prevent monkeypox? Avoid contact with animals that could harbor the virus, that's especially the rodents. Isolate infected patients from others who could be potential carriers. Practice good hand hygiene after contact with animals or humans, and the use of the personal protective equipment for patients. That's for us as healthcare workers, your gown, your gloves, and then your mask. Okay, so the PPEs, what do we do? PPE should be used before we enter anywhere we are managing a patient who is in isolation, and then they should be disposed of and disposed of properly. So disposable gown, gloves, N95, disposable respirators, and sometimes eye protection, either your face shield or your goggles. How do you monitor or how do you manage the patients who are in hospital? They should be isolated, preferably. Remember, we said that it could also be respiratory. So in a negative air pressure room, if it's possible. If not, then you should put the patient in a private or a single room. In the absence of the above, what do we say? A surgical mask may be placed over the patient's nose and mouth, and any of the patient's exposed skin should be covered with a sheet so that there should be no exposed area of the skin or any of the lesion. Then we need to confirm our diagnosis with lab test and then provide appropriate treatment and follow-up support. What about what do we do for the people when they are in home isolation? As much as possible, let's assess the home. If it's possible for the patient to be isolated at home, meaning the patient is not going to share the same sleeping environment with another person, then it's possible to isolate this person at home. Make sure that this person is always wearing the mask when that person is maybe sitting in the room and watching TV with others. Other people who are also seated must also be wearing their mask. As much as possible, they must wash their hands after coming into contact with maybe the doorknobs that this patient has handled or utensils that this patient has handled. They should also avoid contact with wild or domestic animals. Unexposed persons who do not have essential need should not visit. This is not the time for us to be visiting people with monkeypox to show that empathy. If you are not needed in the house, please just allow the people to enjoy their isolation. How long should we isolate people? Isolation should be continued until all lesions have resolved and fresh layer of skin has formed. Remember, we said it takes between 3 to 4 weeks. Following discontinuation of isolation, it's also said that as much as possible, if you have just recovered from monkeypox, please stay away for some time from people who are immunocompromised, people with immunologic disorders, or people on immunosuppressive therapy, until all your crests have fallen, all your crust have fallen, and new skin is formed. Smallpox vaccination. Well, vaccine is known to be at least 85% effective in preventing severe Mpox, because it has also been documented that some people in this current outbreak who got monkeypox, but the mild form of monkeypox, had prior smallpox vaccination. If you do not have smallpox vaccination, then you may have a more severe form of Mpox. Having the smallpox vaccination may prevent you from getting a severe form of monkeypox, but may not protect you forever. The vaccine is not used routinely for public, it is used for mainly the military and also for people, workers that handle a lot of orthopox viruses. So try to summarize that monkeypox is a zoonosis. It's a systemic illness with a characteristic rash, usually self-limiting, should be distinguished from other rash-like illnesses, typically chickenpox, measles. And we learned that measles may have lymphadenopathy, but chickenpox, no lymphadenopathy. Monkeypox monkeypox has lymphadenopathy. Remember also the distribution of the rash start on the face in Mpox and on the trunk in chickenpox. Patients will need to be isolated until the scab have fallen off. Contact precautions are necessary at all times. And currently as a country, no vaccines or specific medications are being used to manage Mpox. These are some of the references. Thank you very much.
Thank you very much, Dr. Komi, for the presentation. He's taking us through the journey of how to clinically identify Mpox cases, the differential diagnosis, how to manage them, and how to even protect ourselves from getting Mpox. So we've ended the 3 technical presentations. So we would jump into the Q&A session. So this is how we are going to go about it. Anybody who wants to ask a question can raise their hand. Then we'll go in order of the hands. So we'll pick 5 questions, get some answers, then we'll come back and pick another 5 sets of questions. So that is how we'll go about it. And on the side, the presenters can look through the Q&A. There are some questions there that need to be addressed. So the first question, Ruth Nkrumah. You can unmute and ask your question. Okay, can we go to the next person? Nene Jarrell.
It looks like a lot of people may have put up their hand unaware. So if the host can put down all hands, then we can now see those who actually intend to raise their hands.
Yes, I think we should do that because I'm struggling to. Christiana, it's your hand up.
Hands.
Sarah, is your hand up? Maybe we can start from Sarah, I think. I'm still seeing some people's hands up. Anita, I think you can ask your question. For Anita, I see it's a new hand, so I think we can start from Anita. Well, people can't unmute. People can't unmute.
Hello. Dr. Salome, Dr. Hammond, you are the host. Can you please allow people to talk if their hands are up? Maybe in the meantime, we can look at the questions in the
chat. Yes, I think we can start from there. The unmuting is not visible on our screen.
Dr. Tawab, I think some of the participants who want to talk, they have been allowed. So
notify them that they've been allowed, so that
they've been allowed. So if you can call out the names so that they can proceed. Thank you.
Okay. Okay. Thank you very much. So Richmond, can we start with Richmond? Yes. Richard Anthony. I'll call Anita again. I think, Anita, you can unmute yourself and ask your question.
Hello?
Yes, I think, Suleimana, you can ask your question.
Thank you so much.
Please mention who you are directing your question to, so we'll know, so the presenters can take note of the questions.
I think it will fall under the one who presented on the sample taking.
Okay, let's go on. Dr. Gifty-Boateng. It will go to Dr. Gifty-Boateng.
Okay, sir. From the presentation, I think she mentioned like that the blood sample is recommended at the recovery stage, and the preferred ones are the craft and then the dry swabs. So from the presentation on I think the last one, we have been told that the virus will be present in the blood at the fever stage. At that stage, it means that the rashes are still not yet appeared. So at that moment, what sample will be recommended? Wouldn't the blood sample be the appropriate one at that stage? Thank you. Hello.
Hello, Dr. Tawab. Do we answer or we wait and take a few more?
I think you can go ahead and answer.
Yes, thank you very much. So the timing is important for us because of the kind of test we are going to perform. At the beginning, the viremia is not enough in the blood. That is why we don't recommend that you take blood samples for testing. Also, if you take the blood sample, normally even with at the recovery stage, we would be doing either IgM or IgG. And that is when we get enough of these antibodies for us to detect in the blood. So we still recommend that at the beginning of the disease, you go ahead with the blood. If the rash is not there yet, because we are going for the case definition, the combination of all of them. So if you don't have the rash, which is part of the case definition, then I don't know what the definition that we would use just because of fever. And so then we suspect monkeypox. So that is what I would say for now. Thank you.
Okay, thank you very much, Dr. Gifty. Can we take the next from Kwesi Nkrumah?
Yeah, okay. Thank you very much. I really enjoyed the presentation. I think my question will go to the medical doctor, the one who just spoke. The issue about getting the appropriate diagnosis is very key. So I'm looking at what are the measures put in place to ensure that the collection, the transport, and the storage of samples are done in such a way that will be able to pick these cases as early as practicable, and then we'll be able to manage them to avoid any public health Pandora. Thank you very much.
Thank you very much. So, Dr. Komi, I think that question is to you.
With the sample taken, it was more towards Gifty, right? Because the question was asked, he was asking about whether measures are being put in place so that we can take this. I'm sure coming from the community, we are looking at, do we have the specimen bottles available? Do you have the swab sticks available so that we can quickly take samples and then send them? I thought that's what the person meant. Am I clear?
Yes, yes. Yes, thank you very much. That is what I was trying to know.
No, then that goes to Dr. Gipsy.
Okay. Please kindly keep me online because I have questions to ask. Thank you very much.
Okay, so thank you very much. I think we had our first case in 2022. So during 2022, we trained all those who needed to be trained on sample collection. And as I said, we have plain tubes with our labs. We also have VTM courtesy. COVID had given us a lot of viral transport medium. We also have swabs available. But in case you don't have any of these within your facilities, kindly contact me, and I'm sure Dr. Tawab will share my details later with you, so that if you need any of these things, kindly contact the National Public Health Reference Lab with my number, and then I'll be of help to you. Thank you.
Thank you very much, Dr. Gipsy, for the presentation. So we'll take the next from Philip Kujo.
Hello, thank you for the opportunity. But my question has just been answered. It was about the availability of the sample case and then how to transport it as soon as possible. I am from the Upper West region, and then I'm just wondering how I can get my sample to Accra within an hour, especially in a situation where we have one flight in the day and looking at the distance. That's my concern. But I think Dr. Gifty spoke about things that are already being kept in place. And then I also want to have a number in case we have a case, you'll be able to contact her for help. Thank you.
Okay, thank you. Thank you very much. So we'll go to Marvin Asare. I think some people are struggling to unmute. So those who want to ask questions, can you kindly unmute? So we'll just use that as instead of raising hands, just kindly unmute them. Okay, so we have okay, yes, you can go on.
Can I go on, please? Okay,
yes,
thank
you can.
Okay, so my name is Marion, and my question is, I want to know if measures have been put in place for those who are coming from outside the country, like maybe from UK or Canada, where cases have been recorded. Have measures been put in place at the airports? Thank you.
Okay, thank you very much. So I think this question, Dr. Lai.
Yes, thank you very much. If the expectation is something like COVID, where
hello, please can I go ahead?
No, please hold on. Could you say please hold on?
Yes, thank you. So I was saying that if the expectation is something like what we saw for COVID, then probably not. But our port health staff are also part of our public health system where surveillance is being implemented there. So our ideas are our staff at the point of entry are also looking for people who may present with these symptoms. Now, how practical it will be that somebody with the kind of lesions Dr. Komi presented would be able to board a flight? Probably not. But of course, with our land borders, we know that people live and move across easily. So the points of entry staff have what they call the ring approach, recognize, identify, notify, and then so they keep looking out for people who could potentially be coming up with these symptoms. And I have to say this, recently we picked 2 cases of cholera at the Aflao border. Some of us may be aware that there's an outbreak there was a protracted outbreak, I should say, in Nigeria. And 2 passengers were picked at Aflao because they presented with symptoms and they were sent to the K2 South Municipal Hospital, and further testing confirmed cholera, and which we were able to contain. So our officers at the various points of entries have been trained, and we will do refresher training as well to make sure that there's heightened surveillance at those points of entry. Thank you very much. Over.
Thank you very much. I think Flandreau can have the floor now.
Thank you very much. Good afternoon. Thank you for all the presentations. Very interesting and very useful. My question is to Dr. Comey, and it concerns the issue of newborn feeding. I mean, it's always a huge problem when these new diseases pop up and you're making recommendations. I think the same thing happened with COVID. Fortunately, there was a lot of very fast research. But your concern is that you are withholding breast milk from a baby at a time when it's likely that the mother's body is just pouring antibodies to protect the baby, but we are discarding the milk and throwing it away. So my question is, is any work on to look at the issue of newborn and whether mother actually significant antibodies and what the role of these antibodies might be in protecting the baby, so that the recommendations can come clearer? Thank you very much.
Thank you very much. Dr. Comey, over.
Thank you very much. And I must say that the recommendations are kind of WHO recommendations. And the first thing I said was that we know that breast milk is the most important thing for the baby. At the moment, it's still being looked at to find out whether we find the virus within the breast milk. So I'm sure they're just erring on the side of caution by saying that avoid breastfeeding for anybody a baby who is born to a mother who has, Mpox at the moment.
That's clear. I just wanted to know if there was any research work going on to clarify it. But yeah, I'm sure there is. Thank you very much.
I'm sure once it's still evolving, we will find something.
Okay. Thank you.
All right. Thank you very much. Agana, I think you have the floor now.
Thank you very much, and thank you for the very good presentations. The first is a contribution on the differential diagnosis. Dr. Comey, I would like if you could add yours. I think everybody forgets that yours is still quite prevalent in many districts. So please, if you could add yours, that will help a lot. The second is, I think somebody already asked it, whether people coming from outside need to go through anything. But it looks like somebody has already answered that one. Thank you very much.
Very much, Dr. Comey, over.
So yes, I think it's a very important differential diagnosis we need to look at. But then we're looking at the very common ones in our setting. So we'll look at yours and also keep that at the back of our mind. That's from an experienced practitioner. So we'll make sure we add that. Thank you very much.
Yeah, Dr. Comey, thanks for making that point, because I think that just for our information, so Dr. Akana used to be the program manager for yours with the Ghana Health Service. So as Dr. Comey mentioned, very senior colleague, making sure that we don't miss yours as well, which could be a differential. So Dr. Akana, thank you very much for joining this meeting and also for this input. Thank you very much. Over.
You're welcome.
Okay, thank you very much. Any more questions? I'm not going to follow the hands, so if you have a question, just unmute the microphone to signal that you are ready to talk. I think all the questions too in the Q&A have been addressed.
Hello?
I think someone says there are questions on YouTube. I doubt if any of the panelists are on YouTube, so we may have to look at that too.
Hello, please.
Yes, Question Nkrumah, yes, you can.
Please, I'm an anesthetist, and looking at some of the clinical presentations, what should be the considerations or concerns of an anesthetist? Because at the district hospitals, we are doing a lot of cesarean sections, and there are instances where you need to intubate, or likely you are very close to the face area of the patient, and we have realized that droplets are part of the ways by which you can get it. So as anesthetist, what should be my concerns or considerations? The other point is that the characteristic rash, is it always centrifugal? Is it absolute or relative? And the other point is that can somebody have chickenpox and Mpox at the same time? Thank you.
Okay, so thank you,
Dr. Kom.
I'll start from, yes, I remember in my slides, I said that you could have co-infections. So we should keep that at the back of our mind. One of the key distinguishing features between Mpox and chickenpox is the distribution of the rash. So most of the time they say it's mainly centrifugal for Mpox and centripetal for chickenpox. The first question was about what precautions you need to take. Remember I said that there's a droplet infection. So definitely you need your face mask. Definitely you need your goggles. Definitely, I said for the N95 mask, you need your goggles. And at all times, it's not because the patient has Mpox, but for every patient, IPC should be standard. And because you work within the environment where aerosols can be generated at every point in time, no matter which patient you are handling, your IPC should be IPC, as we all know. Goggles on, N95 on, your hair, your what do you call it? The overall or the coverall that you are using. So these are the things that we should do. We shouldn't say because of Mpox we have special precautions. The same contact precaution, same droplet precautions that we know already.
Dr. Tawab. Dr. Tawab.
Dr. Salom, yes.
Yes, so I have some of the questions from YouTube, and
Okay.
Let me pick out the ones that we haven't mentioned. Some of them have already been answered. Somebody wants to ask about contact tracing and how to deal with it. And then also, somebody wants to know how long the samples will take. And then they want to know what the role of veterinary service department, especially wildlife division, is in the management of Mpox. They want to know if immunoglobulins for treatment are available for babies born to infected mothers. I think let me stop here and then we can answer, and I'll probably ask any more.
Thank you very much, Dr. Salom, for that wonderful gesture. So I think the role of VSD, I'll give that to Dr. Lai, and also the contact tracing, then the immunoglobulins will go to Dr. Komi. I think for the results, Dr. Gifty has answered that. She says at the time, within 24 to 48 hours, at the time the sample arrives at the lab, the results will be ready. So over, Dr. Lai, the role of VSD, especially wildlife and contact tracing in this case.
Yeah, thank you very much, Dr. Buche. I think she beat me to it. I was also on YouTube trying to jot down the questions. So yes, the first one on BSD and wildlife, I think it's something that COVID has helped us do better. We work very well with these agencies, and particularly when there are zoonosis involved. And so Emergency Operations Center, last week, we had a meeting to look at the National Preparedness and Response Plan for monkeypox, and they were part of it. So they have their role to play, also keeping surveillance in the animal population and notifying us. We do information sharing. They share their situational updates, their weekly epidemiological updates with us, and we also do same with them. So that collaboration is there, and if there's any events in the animal sector, we would also be aware on that. I think the second question is about contact tracing. Again, thanks to COVID, it's something that is commonplace now. And given that we understand the mode of transmission, once a patient is suspected, and if we remember very well from Dr. Arthur's presentation, he indicated that the surveillance goal starts with when a case is suspected. So all the actions we take, including contact listing, starts with when we suspect. If the results comes and is negative, for example, the list then would not be used. But if it is positive, then we'll take the necessary steps. So those contacts will be then undergo the necessary processes, whether it's recommendation that is still on quarantine, they will be followed up by public health staff. And that is why it is critical that when it is suspected, for those of us in facilities where there are public health units, we liaise with them on this. But if we're in a facility where there's no public health unit, then the district health directorate or the sub-district head should be informed so that the necessary public health actions can be undertaken. We're not expecting patients to be the one doing the contact tracing. But once the information is passed on to our public health staff, the necessary measures will be taken. Thank you very much, and over.
Okay, Dr. Comey.
Yes, please. The question was on immunoglobulins.
Yes.
Currently, I am not aware of any immunoglobulins maybe being used at the moment. Is that what the question was about? Sorry, I maybe missed it.
Yes, please. The question was about the use of immunoglobulins for treatment, especially for babies born to infected mothers.
In the reading so far, I haven't come across that being used at the moment. So I have not much to say about that. The recommendation from the WHO is that if the baby is born to the mother, avoid the breast milk, do replacement feeding until such time that the mother, all the lesions have healed and the mother can resume breastfeeding.
Any more questions?
Okay, there are still a few more. Somebody wants to know how long patients are kept, I think, in the health facility or at home when you are talking about isolation. That's for confirmed cases. And then,
yeah.
Okay. And then also, there was a comment. And there was a comment about, I think, the way we're characterizing the condition. We're calling, some people were still mentioning monkeypox, and somebody stated that they were not happy with the language because of the way it's stigmatizing. And then there was somebody was asking, there's a need to keep the person at the facility level if the patient has mild symptoms.
Okay, so maybe let me start on the first one about how long. Like we said earlier on, the disease may last close to about 4 weeks. And we say that the person is no longer infectious when all the scabs have fallen off and new skin is forming. So invariably, we're talking about close to 3 to 4 weeks of isolation for that particular person. Within the hospital, we may do a few days once the patient is stable and can go home. We'll go home and continue home isolation. Even some of the pictures I showed you, most of the patients, we manage them on home care basis. So on the average, between 3 to 4 weeks of isolation until your lesions have completely healed. For the there's another question they asked. Yes. Hello.
They wanted to know about whether they should manage mild cases in the health facility. As in keep them there.
Like I said earlier on, there are people we say that are mild, moderate, sick. But we're all saying that the patients who are inpatients should be the children severely ill or that's immunosuppressed. If not, most patients should be managed on OPD basis. You don't need to keep a well patient in hospital. Even for people who we said who are HIV positive, remember we said that it's dependent on the degree of immunosuppression. Okay.
Thank you very much, Dr. Oliver, for me.
Okay, thank you very much.
Yeah, Dr. I wanted to make an input. I think
okay,
it's a bit on the IPC side, and the colleague's question about how our work puts us at risk is very important to note. I think I put it into the Q&A about another question, and we want to emphasize the need for standard or universal precautions at all times. I think that a lot of times we want to have a suspicion before we sort of touch ourselves about how we are doing our work. We remember that the key recommendation has been to approach our work, working with our patients as though we could give them infection or they could give us infection. I think sometimes we are even thinking that they will give us infection, but the need for our standard precautions goes both ways. So if the nature of our work means that we can easily be exposed unknowingly to infectious patients, then it reinforces the need for standard precautions. And that's why they are called standard precautions. So if I am going to work on a patient and I think I could be exposed to respiratory droplets just by the way I have to do my work around the patient, I need to adopt the precautions. I don't need to think that the patient is infectious before I put on a mask, for instance, before I want to do my hand washing before and after having contact with the patient. I don't need to think that there is an infection or an infectious outbreak before I want to do cleaning of surfaces around where I work, consulting room, on the ward, and the rest. And unfortunately, for various reasons, we are all repeatedly guilty of this. So when we have cases like this, we then are asking about what to be done differently. It should be the routine so that we don't even have to worry about it when we think of such diseases. They are going to come at us, and they are not going to come with a warning bell around their neck. That is why they are even coming to us. So we need to be always prepared when it comes to adopting our standard precautions. Thank you.
Please, let me ask this question. Please, how well are the CHMTs and other community actors being involved in this? Because the issue about home management that has been emphasized, whilst good, we learned quite bitter lessons from COVID, where we were managing some people at home and they were all around in the markets, they were all around the places, they only wear the mask when they are coming to us. How well are the CHMCs and other community actors being engaged to ensure that when we say somebody should isolate for 3 weeks to 4 weeks for all the scabs should fall off before the person can come back? How well are we doing this?
Dr. Alai, over.
Yeah, thank you very much. I think that the simple answer to this is that it's the onus relies on all of us, from the clinicians to the public health people. And yes, you're right. I remember during the times of COVID, people are supposed to be isolated. And when we used, for example, their cell phone numbers, they were miles away from where they are supposed to be isolating. And so, yes, this is a real problem. So we need to marry the clinical and the public health decision making. If there's any risk, as far as we are concerned, that possibly managing at home would put the population at a higher risk, then we ought to make that decision to manage in the health facility where we can be able to manage. I don't have a simple solution to this. I think that it will be dependent on specific situations. So it would need the concerted effort of both the clinical and the public health teams to make the decision on the best way to manage, particularly those that are mild and can be managed at home. Whether the decision will be made to let them stay at home or keep them in a facility until they are less likely to transmit the disease. I hope this is satisfactory. Thank you. Over.
Okay. Thank you very much, Dr. Lai.
Just a suggestion in response. I am thinking also that it may be important to do some education of, for example, community health volunteers and some of the community actors so that they are aware. Sometimes the alarm of it and also the fears they don't understand, and then also the need for them to understand that they need to isolate. So that I don't know what plans you have for that, but that's a suggestion. Thank you.
Yeah, thank you very much. Very, I have to say that that is actually one of the pillars. It's just for the purposes of this group, given that the CPD was focused on clinicians, so we took out our risk communication and community engagement pillar, even though I know some bits of information on that has come up. So thank you very much for that. And I think that we would work on that as well when we are doing the community engagements. Thank you. Over.
Okay, thank you very much, Dr. Lai and Dr. Salome, for the questions. So I think there was one question that was pending. I will take that question, then I'll give Dr. Lai the floor to give us the closing remarks. So there was a question on the difference between the fake and the public health emergency of security concern. So the fake is a public health emergency of international concern, which is usually declared by the Director General of the WHO. So when there's any public health emergency ongoing, the Director General convenes a group of experts to review the situation and then make some recommendations on what level of response or coordination is needed for that particular emergency. And based on that, the committee will recommend to the DG to declare a fake. When you come to the African continent, one of the organs of the AU is the Africa CDC. That is the technical wing that helps in managing public health emergencies in the Africa region. So when there are public health emergencies ongoing in the Africa region, the DG also convenes a group of experts to look at the situation, look at the risks, the resources available, and how to ensure coordination among the African countries. And I mean, after the group of experts also come out with their proposal, a public health emergency of security concern is declared in the region. One is at the global level, one is at the regional or Africa level. This is just to bring together all resources, enhance coordination between all the sectors and countries to be able to respond to whatever public health emergency we are dealing with. So, Dr. Lai, I will hand over to you for the closing remarks, then we would end the session.
Dr. Tawab, I think you left one question out. The question about the oral lesions. Somebody wanted to find out from Dr. Oliver Comey how the oral lesions presented. I also wanted to find out whether the swabs that are used for taking the skin samples are the same ones they use to take the oral samples. Thank you.
I don't know how to put the oral lesions, but they are just like the ulcers we will see, because for the oral lesion, they may not appear as pustule, they may appear as this vesicular rash. And then those with the oral lesions tend to have lesions most of the time in the genitalia area. So then you're able to marry the two. That's what I will say about the oral lesions I've seen so far. Thank you. Mainly on the tongue.
Okay, thank you very much. Also, I think one was for Dr. Gifty, right? Or it's been answered?
Yeah, so Dr. Tawab.
Yes, Dr. Gifty.
So he was asking whether it would be the same swab that we would use. Yes, the same swabs that we use for COVID, for the oral pharyngeal sample taking, the one that we use for the skin, the same swabs. Because of the test we are going to do, which is PCR, we still would recommend that we use the Dacron or polyester tips with plastic applicators, not wooden ones. Thank you.
Thank you very much,
Thank
Dr.
you.
Gifty and Dr. Livercombe.
Okay, Dr. Lai, please over.
Right, thank you very much. So I think what I would want us to quickly remind ourselves of as we started this presentation or this webinar, we set some objectives for ourselves, and I'm not going to ask for responses, but just to refresh our minds on the objectives we set for ourselves and hope that we have been able to achieve these three objectives that we set. First one being that we are clear on the disease Mpox. I know there are a few lingering questions, particularly in relation to the presence of the virus in breast milk and others. But nevertheless, we want to be sure that at least there's some level of clarity as far as the disease is concerned. And we're also clear on the principles underpinning the surveillance, sample collection and transport, the appropriate samples for the time of presentation, and how to get these to the lab, the various samples to be taken. And we've also received information on the type of testing that is done. Case management and IPC in particular, I think Dr. Arthur mentioned universal precautions, and it's important that we bear these in mind as we have to deal with this outbreak. And last but certainly not the least, and the main reason why we had this session, is for there to be clarity on us as clinicians, what our roles are, as far as strengthening our surveillance system to be able to pick these cases when they come to our facilities and respond appropriately. So I want to thank you all very much once again for the time you spent on this call. And we really look forward to seeing some changes in our practice, some heightened surveillance, so that we can be able to pick any case that should come to this country. Thank you very much. Over.
Okay, thank you very much, Dr. Lai, and thank you, everyone. Bye-bye.